The session today is going to be in 3 parts. The first is to talk about these emerging issues in HIV and rehabilitation, and we'll define what rehabilitation is, specifically focused on aging, multi-morbidity, and mental health. And I'll report back on a study that was done. It was a national web-based survey called the HIV Health and Rehabilitation Survey. We'll then talk about and move into the concept of healthy aging and specifically focus on exercise as a rehabilitation intervention to promote healthy aging as a living strategy with HIV, and provide you with some updates on some various research that's being done locally here and in close partnership with Casey House and the YMCA related to that. And then finally share with you some current resources that are available related to HIV and rehabilitation. So there was a study done probably just over 10 years ago now out of British Columbia. This was a postal-based survey, and this was done by some colleagues who actually at the end of the day were quite surprised that when they mailed this survey out to individuals living with HIV in BC, that over 80% of the respondents were living with some sort of impairment like a muscle weakness or pain or fatigue, some sort of activity limitation or difficulty carrying out a daily activity, and a difficulty in a participation restriction or engaging with others in social society. What they were also surprised is that the high prevalence of mental health issues that were reported on in this particular survey. So a few years later, after this survey was done, there was a follow-up mailed survey that then asked rehabilitation professionals and HIV healthcare specialists, how often do you refer to rehabilitation professionals for your patients? And we also asked rehabilitation providers, how often do you work with people living with HIV? And the results of this survey found that very few physiotherapists or occupational therapists or speech-language pathologists actually work with people living with HIV. 61% of the survey respondents had never knowingly worked with someone living with HIV. Half of the respondents agreed that many rehabilitation professionals were uncomfortable with the idea of working with the population, and only 19% felt that they had the adequate knowledge and skills needed to work and treat and assess people living with HIV. So there's certainly a bit of a gap that we're seeing with respect to the health-related challenges of the need related to rehabilitation and the actual services provided by traditional physio and occupational therapist rehabilitation providers. So as a background, we know that as individuals are living longer, they're now experiencing the physical, social, and sometimes psychological health-related challenges of HIV, but also the consequences of long-term treatment and multi-morbidity that could be associated with aging. Disability is a term used commonly in the rehabilitation world, but it's also, I'll show you, has been defined by the community as any health-related challenge, like a symptom, an impairment, difficulty carrying out a daily activity, challenges to social inclusion, and sometimes uncertainty or worrying about the health in the future, living with HIV. Rehabilitation is a field. I'm a physiotherapist by training, and so I'm part of this rehabilitation realm. And rehabilitation professionals and services can help individuals manage their day-to-day health challenges. But to the extent we really didn't have a good idea what the nature and extent of this disability or health-related challenges that people were living with, the rehab services that individuals were accessing, and in the absence of those, what were just people doing day-to-day in their lives in order to address their health-related challenges. So I'll start with a little bit of background. This work describes a conceptual framework that was developed to describe the health-related challenges experienced by adults living with HIV. This was a project that I had the opportunity to do as part of my graduate studies, and it involved a series of focus groups and interviews with men and women living with HIV here in Southern Ontario, primarily Toronto, asking individuals, what are your physical, social, and cognitive health-related challenges? How do those challenges impact your overall health? And participants described this concept of these health-related challenges as being what we term here as episodic disability. So individuals might be experiencing a series of unpredictable, at times, periods of wellness and illness living with HIV, And those major fluctuations in health could be triggered by things like receiving word of a diagnosis, experiencing a health-related infection that might land an individual being admitted to hospital. And superimposed upon all of these ups and downs living with HIV over time are these contextual factors, so things in the environment like social support, interactions with healthcare providers, food bank, housing, ODSP that might help alleviate some of these health-related challenges. And there's other factors such as stigma and discrimination that might exacerbate those experiences of disability. And then there's also the things intrinsic to an individual, such as behaviors, attitudes, and beliefs that also helped to mitigate some of those health-related challenges living with HIV over time. And those are indicated here in pink. Now, superimposed upon those major fluctuations in health over time are the light blue squiggly lines here, which are the day-to-day fluctuations or the day-to-day episodic nature of HIV that could be the fluctuating good days and bad days living with HIV over time. We then took this experience from the qualitative study that was done in this episodic disability framework and then actually used the categories that were in this framework to develop something called the HIV Disability Questionnaire. And this was because working clinically as a physiotherapist, we didn't really have any good tools to adequately capture the specific health-related challenges experienced by individuals living with HIV. So this HDQ, as we call it for short, is a questionnaire that includes 69 items, and it measures the presence, severity, and the episodic nature of disability across 6 domains. And these 6 domains represent those dimensions that were in that episodic disability framework. So physical symptoms and impairments, cognitive symptoms and impairments like difficulty focusing attention, difficulty with memory, mental and emotional health challenges, this uncertainty or worrying about the future living with HIV. And this was a new one that popped up with us for many of the interviews and focus groups. This was one that we hadn't anticipated. And this was the feeling that individuals sometimes worried about when their next episode of illness might arise, how severe it might be, and what the consequences of that illness might be. Difficulties carrying out day-to-day activities indicates anything from walking from A to B, negotiating stairs, ability to carry out one's daily activities, and challenges to social inclusion includes questions related to work, personal relationships, and travel or leisure activities as well. So this bottom here underneath provides an example of what a question would ask in the HDQ, and this is particularly asks about fatigue, and individuals would rate whether they experience that fatigue on that given day anywhere from not at all to extremely. And for every health-related challenge, in order to capture that episodic nature, we also ask whether that challenge fluctuated over the course of the past week, and that could mean it got better, it got worse, or maybe it did a little bit of both over the course of the week. We've then been able to take this questionnaire and validate it. So we wanted to make sure once you develop a questionnaire, you want to make sure that it's measuring what you want it to measure and that it's consistently measuring what it's supposed to be measuring. So we went through a series of validation process with adults living with HIV here in Toronto and Hamilton area, as well as had the opportunity to collaborate with some folks in Ireland as well. And this work's been published, and I could tell you a little bit about some of the similarities and differences between the two groups if interested at the end. So that gives you some background about what this concept of episodic disability is and how we've been going about trying to measure it over time. Now getting back to sort of this recent research project, which is this HIV Health and Rehabilitation Survey. We used this concept of episodic disability and the HDQ in order to actually capture the disability, the concurrent health conditions people were living with, the rehabilitation services that they were accessing, and also we wanted to describe what the nature and extent of the day-to-day living strategies people were using in order to deal with their health challenges, and to explore about how do these pieces all fit together and what does that all mean. So the HIV Health and Rehabilitation Survey, or HHRS for short, as we call it, was a collaboration of over 20 researchers, clinicians, community-based organizations, people living with HIV in Canada, as well as the United Kingdom. And so it was a collaboration of which Casey House was as well a key collaborator in this work. We conducted a cross-sectional self-administered web-based online survey. That means it was a survey that went out online. You clicked on a link and it was asks individuals to complete this at a given point in time. We invited adults who are living with HIV in Canada to participate, and the recruitment process involved a four-step process with our collaborator and knowledge user organizations across Canada. The survey instrument took about anywhere between 20 to 45 minutes to complete. It included 6 different sections that captured all of the concepts of interest that we were interested in measuring. That disability, rehab services use, comorbidities, living strategies, social support and stigma, and demographic and disease characteristics. And I just want to point out that our definition of rehabilitation was very broad. We knew from those earlier studies that probably very few people were accessing the traditional forms of rehab, like physio and OT. But we also wanted to ask about the non-traditional forms of rehabilitation, like complementary and alternative therapies, as well as accessing services at community-based and aid service organizations. So the methods were a fantastic undertaking upon themselves, and this study could not have been done without the 28 collaborator knowledge user organizations that were essentially responsible for sending out e-blast invitations and recruiting members from the community to take part in this survey study. We also had a community member living in the UK with expertise in film who developed something like we call the Penguin video, which was a little cheeky video to help with recruitment strategies as well. And we learned a lot about what it's like to do a web-based anonymous survey with the HIV community. And we did offer a token of appreciation where participants were given a $25 gift card for Starbucks at the end of the day. And so we've been able to sort of write up some of the considerations for folks who are interested in doing similar type of research. So now to the results. First of all, who participated in the HHRS? Well, the respondents were primarily, so at the end of the day, there were over about 4,800 invitations that went out. And after going through the cleaning process of the data set, we were left with 941 complete responses to the questionnaire. The majority of participants were living in Ontario in a metropolitan area. The majority of respondents were men with a median age of 48 years. Median year of being diagnosed with HIV in 2000, and 43% of the respondents were 50 years of age and older. Okay. When we looked at the characteristics of the sample based on age group, so we compared those who are 50 years of age and older to those younger than 50, the majority of older respondents in this survey were men living in British Columbia, who were born in Canada and tended to be living alone, had an earlier year of diagnosis. Fewer were working for pay, so they tended to have incomes off of pensions or long-term disability. And they tended to rate their health status as good, fair, or poor, opposed to excellent or very good. We then had a section in the HHRS that asked what other health-related conditions individuals were living with in addition to HIV. And the respondents were living with a median of 3 additional concurrent health conditions. So that's on top of living with HIV. We were a bit shocked actually to find that 72% of the respondents were living with 2 or more conditions in addition to HIV. And these are in descending order here of prevalence. So mental health condition, which was defined as anxiety or depression, was experienced by the highest proportion of the sample, 42%, followed by muscle pain and joint pain or arthritis. And you can see the list go down from there. When we looked at these conditions by age group, where we compared older participants, again defined as those 50 years of age and older, compared to younger adults, older participants tended to have a higher proportion of comorbidities compared to the younger respondents, and they tended to more of them were living with a mental health condition, things such as muscle or joint pain and peripheral neuropathy, high cholesterol and blood pressure, neurocognitive decline, and some bone and joint disorders such as osteopenia or osteoporosis. For other comorbidities that were experienced by less than 10% of the sample, these health conditions here, were still noted a statistically significant difference between the older and the younger participants, whereby older participants tended to have, there were higher proportions living with cardiovascular disease, bone and joint disorder, COPD, and so on. Okay. Moving on from the health-related challenge or the concurrent health conditions, we asked about those health-related challenges or disability that people were living with in HIV. And we did this by using this HDQ or HIV disability questionnaire. And the responses here show that the scores on the HDQ range from 0 to 100. So higher scores indicate a greater presence, severity, and episodic nature of disability. And for both younger and older participants, the take-home message from this slide here is that the highest presence and severity scores of disability were in this uncertainty or worrying about the future domain, followed by mental and emotional health challenges, challenges to social inclusion, and so forth. The episodic scores, so those are the fluctuations in day-to-day challenges, were highest in the physical health domain. And that makes sense because we would expect the questions related to the physical health domain were around fatigue, headaches, pain. We would expect those things to fluctuate more on a daily basis than the questions in the social inclusion domain tended to ask about employment or personal relationships, so less likely to fluctuate on a daily basis. So that uncertainty was the highest presence and severity scores. And when we actually compared the younger to older participants, the older participants tended to have higher physical health challenges and difficulties with day-to-day activity challenge scores compared to the younger participants. Although, compared to the older participants, it was the younger participants who tended to have slightly higher uncertainty, presence, and severity scores. So one might think that older participants in this sample were longer-term survivors living with HIV. They may have had less uncertainty or less worrying about their future with HIV, opposed to individuals who are younger and may be living with a more recent diagnosis. When we focused in on the actual health-related challenges that were episodic in nature, that feeling sad or down or depressed, that those mental health challenges were experienced as episodic in 26% of the sample, followed by feeling anxious in 25%, trouble sleeping 26%, and then various forms of fatigue, diarrhea, headaches, and aches and pains that fluctuated as well between 26 and 30% of the sample. This slide is basically demonstrates how these dimensions of disability, how they all relate together. So it is kind of complicated. We did something called a path analysis, and it's trying to look at how do these pieces all fit together. The take-home message here is that uncertainty and mental and emotional health challenges are a key component of this experience of disability. Having uncertainty or worrying about the future is a strong predictor. So this 0.53 indicates a strong predictor of someone having mental and emotional health challenges, which then is a predictor of someone having challenges to social inclusion. In fact, after you remove some of the physical health challenges and the cognitive health challenges from this model, it's really the uncertainty and mental and emotional health challenges that really have a very strong influence on predicting one's challenges to social inclusion. So this particular series focusing on mental health and uncertainty, which I think is very closely related to mental and emotional health, I think is a key component to one's ability to interact with respect to social inclusion and overall health. So given that these were the health-related challenges, we were also, as mentioned, interested in what kind of rehabilitation services individuals were accessing in order to address those health-related challenges. And of the sample, 17% had seen a physiotherapist in the past year, 6% a physiotherapist, and 3% a speech-language pathologist. Among those who had seen one of these rehabilitation professionals, over half had felt they wanted to see that professional or felt that they could benefit if they had seen them more often. And 71% who had seen them felt that their interventions had helped reduce, minimize, or prevent the health-related challenges they were experiencing. In the absence of those accessing those traditional forms of rehabilitation, individuals were accessing community-based organizations and complementary and alternative therapy providers. There were actually 67% of the sample had accessed a community-based organization or an ASO. This is not surprising to see this as being a high number, because if you think this is how participants were primarily recruited for the research study, were through a lot of the ASOs in the community. And 62 to 71% felt that by accessing those organizations, it had helped improve their overall health. When we focused in on the types of interventions that individuals were accessing, for those accessing complementary and alternative therapy providers, it was most likely to see a massage therapist, a chiropractor, acupuncturist, or naturopath for things such as counseling, pain control, health promotion, and acupuncture. Okay, so very few people, despite the role and the evidence, very few people accessing formalized rehab services. Some were accessing community-based organizations, but in the absence of accessing any formalized service at all, we were interested in what day-to-day living strategies people were using. And these are things such as behaviors, attitudes, and beliefs that people adopt in their day-to-day lives. Okay, well, sorry, apologies for the slide being a little bit garbled, but these were additional questionnaires that we asked about people's mastery, their coping, stigma, or social support. And if we look at this, the take-home message here is that older participants tended to have lower stigma scores and tended to exhibit lower what we call maladaptive coping strategies. So yes, less substance use coping or less behavioral disengagement type of coping compared to the younger participants. But no differences when it came to mastery or social support. When we asked these 10 related questions about what kind of social interaction strategies you used in your day-to-day lives, the number and the proportion here represent the proportion of participants who engaged in this living strategy either most, meaning a few times a week, or all of the time, meaning every day. And I would see the most frequent ones were spending time with friends, partners, family, or pets, as well as trying to reduce or eliminate relationships or activities that I believe are harmful to me. And one of our colleagues and friends uses the term social pruning, as which seems to resonate with the last one here. We also asked 41 questions or 41 living strategies about what kind of activities people were engaging in. And some of the most common ones were here, things like lifestyle. So making sure individuals getting adequate sleep, eating well, a good dental hygiene by a high proportion of participants engaging most or all of the time. Attitudes and beliefs around considering oneself healthy with HIV, accepting and valuing the good days and the bad days, living with HIV. Taking medications as discussed with a doctor, and as well, which I'll focus on a little bit later, is this concept of exercise, whereby 37% of respondents were engaging in exercise most or all of the time. When we broke things down by age group, compared to younger participants, a higher proportion of older adults, so 50 years in age and older, tended to engage a higher proportion tended to engage in things like the good dental hygiene, healthy eating, and the positive attitudes and beliefs around accepting good days and bad days living with HIV, focusing on maintaining one's health, having a positive outlook on life, and planning ahead or establishing a daily routine. Compared to adults less than 40 years of age A higher proportion of older adults, again, made sure they got adequate sleep, considered themselves healthy, tried to avoid things or people that stressed them out, believed that one could survive and overcome challenges living with HIV, prioritized and tried not to overdo things. Some used faith and spirituality and tended to take medications as discussed with their doctor at a higher proportion. And this slide demonstrates a number of the other living strategies where there really wasn't any difference between the age groups across the younger, middle age, and the older participants in this sample. And you can see some of the strategies that we asked here. Many of them are positive living strategies, or one might interpret as having a positive influence on health, but we also asked about strategies that might have negative influences on health, such as smoking cigarettes, tending to overdo things by working long hours that might have detrimental effects on one's health, and so on. So no real difference here in age group, and you can see the proportion of participants that were engaging in these behaviors or attitudes and beliefs on a most or all the time were much lower in numbers. So in summary, the results from the HHRS really say that, there's a high level of multi-morbidity that is experienced by adults living with HIV in Canada. 72% of the participants in this study were living with 2 or more health conditions in addition to HIV. And uncertainty and mental and emotional health challenges seem to be these key dimensions of disability. And uncertainty in particular is a strong predictor of having mental and emotional health challenges with HIV. Mental health challenges such as anxiety and depression were the most prominent concurrent health condition among the sample, experienced by 42% of the respondents. And it also tended to be one of those health challenges that were episodic, potentially those good days and bad days where mental health might fluctuate in that way. Older participants in this sample were living with more multi-morbidity, and a greater proportion were living with mental health conditions. And the living strategies or rehabilitation services that people were accessing tended not to be the physio and the OT, but individuals were left to access available services in the community or the day-to-day living strategies adopted on their own, such as maintaining a sense of control over their life and HIV, and maintaining these positive attitudes and beliefs. So I think the results really sort of resonate from a rehabilitation perspective on areas in which we might target interventions and strategies in order to address this uncertainty or mental health challenges living with HIV, and sort of learn from what some of the key living strategies that have tended to really work well for individuals and help mitigating those health-related challenges. Some caveats, because there's always limitations with research. This particular HHRS included primarily respondents from Ontario living in a metropolitan type area, and the participants were recruited primarily through ASOs. This was an English-only questionnaire as well. The other thing to mention, it is all self-report. So one might speculate whether or not someone might over-report concurrent health conditions they were living with, or potentially one could under-report if they weren't potentially knowingly living with a particular health condition at a given time. I'll say that the community-engaged approach was critical to using this online survey methodology. And this is really just a snapshot of the results. Our colleague, Francisco Ibanez Carrasco at the OHTN and Universities Without Walls, put together a case study on our experience taking a community-engaged approach to this particular study. And we've also got fact sheet summaries that are at the back as well that you can pick up that provide some of these key messages. And they're available online as well. So lastly, I'd just like to acknowledge some of the key players who are involved in this particular research study, in addition to the team and who are involved in some of the analyses. And then I want to focus back on this 37% of participants who said that they were exercising most or all the time. So in the absence of being able to access formalized physio and OT, which there is evidence to support, but unfortunately it's very hard, and there are a lot of barriers financially related with delisting that we've gone through in Ontario. Very few people can access a formalized physio and OT unless you're admitted into a hospital, for example. Exercise is one rehabilitation strategy that can be used for people living with HIV, and it's a rehabilitation intervention that actually has a lot of research evidence behind it. So there have been high-level systematic reviews that have been done to demonstrate the effects of exercise, both aerobic and resistive. And this study was recently published with some colleagues. Rick Glazier is a family physician at the health center at 410, and he was probably one of my mentors who got me interested and involved in doing research in this field altogether. So fortunate that I still have the chance to work with him. But I want to give you a snapshot of what some of the results were from this systematic review that looked at the effects of exercise, and all of these indices ranging from CD4 counts, viral load, strength, weight, and body composition. And if you want more details, you can access the article online. So we use something called a Cochrane Collaboration Protocol. This is a very rigorous process whereby you take results of individual studies and you combine them together. And the idea is that you have the strength in numbers. So the more studies that you have, the more studies that you can statistically combine the results of those individual studies, the more confident you can be with the results that you're getting at the end of the day. So we looked for any randomized controlled trial that was published looking at the effects of exercise interventions. And the exercise intervention had to be 3 times a week for at least 4 weeks with adults living with HIV. So we searched databases, we went through a series of screening articles for inclusion, and at the end of the day, there were 24 studies that looked at aerobic exercise, 20 studies that looked at resistive or strength training, and there were 14 studies that included a combination of both resistive and aerobic exercise, because you don't often see the two in isolation so much anymore. There were anywhere from 900 to just over 1,200 participants that were included in these pooled systematic reviews. The age ranged from 30 to 49 years of age. About 22 to 23% of the participants in this review were women. You can see the withdrawal rates here ranging from 20 to 24%. And the interventions were primarily around the 5 to 6 week range, but there was one study that was 52 weeks in duration. And for the most part, I want to highlight here is that these studies, these randomized control trials, were very highly supervised. The interventions involved participants going to a gym or a research facility that engaged in an exercise intervention that was supervised by highly trained personnel. So what were the results? So this is what you call a forest plot. Each row here represents an individual study that was included in the review that measured CD4 count. Okay? You've got the list of the number of participants that were in each of those studies in the exercise group versus the non-exercising control group. And each of those lines represent what the results were with respect to CD4 count for each of those individual studies. The broader the horizontal line, the less precise that study is. Okay? The smaller the line, the more precise that study was. The diamond at the very bottom represents what happens when you pull the results from all of those 14 studies together, and that's called a weighted mean difference. The vertical line here represents what no difference or no difference in CD4 count would be between exercise and control group. So if the diamond touches or crosses that vertical line, it demonstrates that there's no statistically significant difference between the exercise and control group for that outcome. So here, it might be difficult to see with the naked eye, but the diamond actually just touches that vertical line. So it kind of is trying to sort of trend towards favoring the exercise group. But ultimately, at the end of the day, there's no whopping evidence that exercise is going to change one's CD4 count. So no difference between exercise and control. When we look at viral load, there were 6 studies that looked at viral load. The diamond here crosses that vertical line. The results here demonstrate no significant difference in the change in viral load between exercise and control groups. But where we do see some significant differences is when it comes to cardiopulmonary fitness, like VO2 max, for example. where results found a statistically and a potential clinically important improvement in VO2 max, which is a measure of cardiopulmonary fitness among exercisers compared to non-exercisers. When we looked at weight, there was a statistically significant increase in body weight among exercisers versus non-exercisers, and a greater increase in weight was found among the studies that involved resistive training compared to no exercise. And that makes sense when you think about increases in weight could represent an increase of muscle mass. When we looked at body fat, there was a statistically significant reduction in percent body fat. So now the diamond is to the left, demonstrating a reduction in that outcome, favoring the exercise group over control. With strength, we found there were only 2 studies that we were able to combine statistically, but those studies demonstrated a significantly greater increase in upper body and lower extremity strength among exercisers, resistive exercisers compared to aerobic exercisers. And then this is an interesting one where the quality of life, I think, comes back in, is there were 2 studies that measured quality of life using something called the SF-36. There were improvements among exercisers for 6 out of 8 of the quality of life domains, but there were 3 of them that actually demonstrate potentially clinically important improvements because the improvements were greater than 10 points on this scale that ranges 0 to 100. And this was mental health, role emotional health, and physical function. So at the end of the day, exercising 3 times a week for at least 5 weeks is safe and can lead to improvements in cardiopulmonary fitness, body composition, strength, and quality of life, and particularly mental health among exercisers compared to non-exercisers, with not anything dramatically happening when it comes to CD4 count and viral load. However, it also demonstrates that there's a level of immune and virological safety when it comes to exercise for adults living with HIV who are medically stable. Some considerations, like the caveat here, because there's always the limitations with research, keeping in mind that these studies included primarily individuals ranging from 30 to 49 years of age. They were mostly men. Few were living with other health conditions, and these studies were done in primarily resource-rich countries in highly supervised settings. Okay? And they also only involve the individuals who stayed in the studies. So we actually don't really know what happened to individuals who withdrew, or we don't have really maybe a good sense of what the reasons why individuals might have withdrawn from these studies. So our question is do these benefits also apply to people living with HIV and other forms of complex multimorbidity? And how does exercise actually translate itself into a sustainable real-world community setting over the longer term?
I'm going to talk about a few of the local exercise studies that we're running. So the first one's called the Implementing a Community-Based Exercise Intervention to Improve the Health of Adults Living with HIV. So last year, between the months of May to September, there was a launch of a pilot study that was run under Dr. Kelly O'Brien over at the Department of Physical Therapy at U of T, and we paired with the YMCA at the Central YMCA over on Grosvenor. So I'm going to launch into that. So first and foremost, I'd like to thank our pilot study team and also the collaborators and knowledge users that were involved in our study. So the slide looks familiar, but just to go over it, so we do know that adults aging and living with HIV are also experiencing many other comorbidities. However, what we don't know is that there is no developed community-based exercise program for this aging population living with HIV across Canada. So our interest, I'm over in the Episodic Disability Unit. So with episodic, that keyword of episodes, is that what health may look like for that individual may be very different in comparison to someone else. So this, of course, is impacted by many different variables, as mentioned, such as medication or treatment, the history, right? So even substance use or smoking cessation, also any comorbidities and genetics. With launching this study, it's really important to capture what health may look like for many people living with HIV. So the purpose of the pilot was to test a community-based exercise intervention with adults living with HIV to reduce the disability experienced by them and to determine the optimal implementation. So the methods used. So we had a study design over a 4-month period involving 2 waves, so approximately 30 people. And the inclusion criteria of the study was that you had to be 18 years or older, living with HIV, based in Toronto, and consider themselves medically stable and safe to engage in exercise, and willing to participate in the CBE program. So recruitment was done primarily through 4 organizations that included the YMCA, Casey House, Toronto PWA, and Realize, formerly known as the Canadian Working Group on HIV and Rehabilitation. And this was done through posters, brochures, recruitment cards, and word of mouth. So it picked up like wildfire. So the intervention. So we had 7, for the pre-intervention of those 4 months, we had 7 fitness instructors. And those 7 fitness instructors partaked in interprofessional learning modules that was supplied by Realize, formerly known as Quicker, to help train and work with the community. Our intervention when launched, so this was over a 16-week period, and this combined those exercises of aerobic, resisted, neuromotor, and flexibility training. Participants were asked to exercise 3 times a week for a duration of 90 minutes long for each session, and one of the sessions were supervised, progressed and tolerated weekly by the YMCA fitness coach over at the Central YMCA. This did consist of individual or group-based exercise classes, and also within those 4 months, we had 4 sessions run with monthly self-management and educational sessions, which I'll get into later. And participants were asked to keep an exercise log, which was paper-based at the time, throughout the study. So with that said, this assessment, so participants were screened with the research coordinator, and then they completed orientation at the YMCA. So we did assess cardiopulmonary fitness, strength, weight, and body composition, and flexibility with those fitness assessments. More so the contextual factors and the demographic characteristics. This was captured with questionnaire assessments that the participants would complete with the research coordinator. And also participants were engaged in neurocognitive assessments at the baseline month of 0, 2, and 4 months. So the measurements. So the self-reported questionnaire. So measured at those baseline month, 2, the next bi-monthly, and 4 months by the research coordinator, we used the PHQ-9 at that time, which is a depression scale. So this looked at, participants were asked on many different things listed with both extremities. So for instance, an example question would be, over the past 2 weeks, did you engage in overeating or did you have a lack of appetite? The scale that they would circle the number accordingly to would ask them based on none of the days, some of the days, most of the days, nearly half the days, or all of the days. So these were some of the questionnaires that participants were asked to complete. So as Kelly had talked about at the HTQ, so this is what we did use in our exercise intervention study. And as mentioned, it was a self-reported questionnaire. So this did ask participants how they were feeling today. So for example, the bottom does provide, I feel tired when doing my usual activities. So column A would ask them to check, mark the box accordingly based on how they felt, and then ask about that fluctuation in column B. Has it changed over the past week? So the results. So what were the results of the pilot study? So 31 participants were recruited and eligible to and agreed to participate. 3 participants, however, did withdraw due to health reasons or lost to follow up with the research coordinator. 28 out of the 31, so that's approximately 90% of participants, completed the baseline assessments, with a total of 19 that completed the final 4th month assessment. So we did have participants that were recruited in 2 waves. So this meaning that when we say those assessments, some participants didn't complete both the questionnaire or the fitness assessment, or they completed either or for those bi-monthly follow-ups. So the characteristics of the participants at the baseline. So this is a breakdown of our 28 participants. So the age range that we looked at was about 36 to 64 years of age. It consisted of mainly men, so 74% of our sample size was about 20 men. The median year of diagnosis was in 2000, and 27 participants out of the 28, so 96% were currently taking ARVs. And mainly, our sample size, so 43%, so 12 out of those 28, overall generally perceived their health as very good. So this being said, the median number of comorbidities our sample population was living with was a total of 4. So 82% were living with 2 or more comorbidities consisting of mental health conditions. So as you can see, their mental health was actually ranked the highest and was present in 57% of our sample size. Sorry. Okay, so multi-morbidities. So we see here is a breakdown of the concurrent health conditions that our participants were experiencing. So asthma, addiction, hepatitis B, which was present in 53%, also MS, Parkinson's disease, and TB. We saw a majority living with these conditions along with HIV. So with this list, we saw prevalent in more than 20%, as I mentioned, of those 28 participants, was depression and anxiety. These are examples of the mental health, right? So you'll see 16 of the 28 there. Goals of participants at the baseline. So the larger words here represent the greater number of participants that articulated this goal. So as you can see here, cardiopulmonary endurance, weight loss, muscle strength, and also mood and their mental health were huge goals amongst our participants. So the participant activity levels. So participants were asked about their current exercise activity. So here you can see that 36% of the baseline month currently were exercising, but not regularly entering the study, versus 42%, which is bolded at the bottom, that at the completion of the 4 months were exercising regularly, but had only begun within the last 6 months. So approximately over half of our sample had experience with current exercise. So our implementation process. So participants were prescribed an array of exercises, as mentioned. 32% completed their exercise log weekly, and 54% of participants attended more than or equal to 40% of those weekly supervised sessions with the fitness coach. 61% of participants exercised independently outside of the YMCA. So that means they were either walking, swimming, exercising at the home gym, or the office gym. 43%, so that's 12 out of the 28, experienced changes in their health status during the study. So there was a lot of progression throughout the program. We saw that 75% of our participants actually changed their fitness program during the study, and most were increasing the frequency and intensity of exercise. So about those education sessions that I mentioned earlier. So we did run 4 sessions, and this consisted of physicians, dietitians, PTs, and OTs, and also a naturopathic doctor that came in as guest speakers. This was held over at the YMCA in our community room. So we saw that the first session had the highest attendance at 63%, so it's 19 out of 30 participants. And the general feedback from our participants was that it was positively received. This provided participants with the opportunity to learn and engage and also ask questions, as well as socialize with one another. What we find was that participants oftentimes will focus on the physical, but it's good to attend these sessions and also do that mental health check-in at times. So reasons for not attending. So there were challenges with scheduling, so sometimes hard to juggle, or there were conflicts. Also commitments with work and balancing the medical appointments that they had to attend or family matters. And some of our participants were away or out of town or traveling for work or busy. There were a lot of fluctuations in health as well, which we picked up with the episodic nature. So feeling unwell or not physically able to attend their exercise sessions or their questionnaire assessments at times. Feeling tired or experiencing pain or undergoing surgery. Also migraines, back spasms, and stomach issues at times with IBS, for example. So we saw that 20 to 30% of our participants experienced episodes of illness throughout that 4-month duration. The other thing was also a lack of motivation at times. So with the pilot study results, so what we see here is that was that all 19 participants that did complete the intervention stated that it was beneficial. So comments that included were, I'm not afraid of the gym anymore, an opportunity to work with a trainer one-on-one, which they found very beneficial, and also to use machines or learn about the different equipment that they had no idea existed, and also someone to push me and show me another way of exercising. Participants found that they had better sleep habits, increased strength, less stress, and less stiffness in their body. They all felt that the initial meeting with the fitness instructor was helpful, and they were able to speak about their medical issues at comfort and plan exercises accordingly, and set small achievable goals as they moved throughout the program. 72% of our participants felt that they did achieve their goals that they set at the start of the study. So whether that was an energy level increase, body fat reduction, some experienced no weight change, and some achieved others while they were a work in progress. So over 60% of our participants that completed the 4-month intervention, they did, with this being so successful, there was an extensive interest from our community in the study, and we were able to recruit our sample within 8 weeks. The partnership at the YMCA and also with our knowledge user organizations, Casey House included, and the research team and YMCA staff were really critical to debrief as we worked through that process. The coaches at the YMCA were really knowledgeable and supportive with our participants, and some considerations for the full CBE launch that I will get into in a bit were strategies to mitigate those last-minute cancellations or the no-shows to the fitness assessments and coaching sessions with this episodic nature of HIV. Also streamlining the communication between the participants, the coordinator, and the coaches, creating an open communication to really guide them along. Few, so 32% completed that exercise log, and they found it very tedious doing a paper-based log. So there was a bit of a respondent burden also with the questionnaire and assessments. So our conclusion was that the community did positively receive this, who completed the pilot study, but there was also a need to identify those strategies, right, to maximize adherence to exercise and enhance that measurement of physical activity, and reduce that burden of assessments on the individual that was partaking in our CBE implementation. Okay, so I'm going to talk about the current study that we've launched, and that happened in July of this year. So this is titled Translating Exercise into the HIV Community. And I'll just go over a few things. So we did launch this in July. So the purpose of this was to evaluate that transition of the community, the CBE intervention for adults living with HIV in the community. And this was to determine the extent of adults with HIV that they participate in the CBE intervention, really assess the effect of the intervention on health and disability outcomes, also assess the engagement, right? So the level of adherence to stick to a program over a long duration of time. So this is this study, which I will pull up the study timeline and go through it. It followed similar inclusion criteria, so adults over the age of 18 or older living in Toronto, was Toronto-based, and able to safely engage in exercise and commit to a 22-month-long study. So here I've just developed a recruitment. So recruitment kind of took off in July, so we saw that it kind of picked up like wildfire. So we did essentially recruit through these community-based organizations listed. So a few were ACT, the Women's HIV/AIDS Initiative over at ACT, PWA, a few of the focus groups, so Women's Health and Women's Hands, PWA Family Services Toronto, Casey House, etc. So we see also word of mouth, so had spiraled with participants engaging and spreading it to their friends, and the YMCA, and also it spread at clinics, so Maple Leaf Hassle-Free Clinic and the Sunnybrook Pain Management Clinic in Mount Sinai. So this is a breakdown of the study timeline here. So I'll go over this. So we are recruiting 120 participants. I am currently at about 113 enrolled and eligible to participate in the study. So with the study timeline, participants are recruited in waves of 30. So there's 4 waves of 30. I'm on the last wave. So what will happen is the individual will first complete phase 1. So that's a baseline monitoring phase where for a period of 8 months, participants come in for bi-monthly assessments. So that's a questionnaire assessment and a fitness assessment done at the YMCA. And that happens over 32 weeks. And why we do this is to really capture what episodic illness may look like and those changes in health status that 120 individuals may be going through. With that being said, 120 people living with HIV and any other comorbidities will have also different goals set. So the beauty of this study design is that in phase 2, before launching the individual into the community-based, that intervention, the exercise program where we ask them to exercise 3 times a week, one of those sessions supervised with the fitness coach over at the YMCA, is that individuals are going to have different goals, such as weight gain is something that came up, right? Oftentimes with social media and things like that, weight loss is something that's really focused on, but weight gain and strength building and things like that. So the participant will meet with the fitness coach and they'll work on a goal attainment scale. And these exercises that we're monitoring, such as aerobic or resistive training, are worked into their exercise plan. So oftentimes participants may have a lot of stigma or fear around engaging or increasing physical activity when they don't really have an exercise regimen. But what I stress is that, we're here to support you and work alongside with you over that 22-month duration. So with that being said, we've also incorporated those educational sessions, so 6 sessions this time, and that'll happen over the phase 2, the 6-month period, where participants will attend the YMCA with dietitians, nutritionists, and healthcare specialists, and they're more engaged with question and answer periods. And then after that, you'll see phase 3 is another 8 months where we monitor the individual. So this is called the post-intervention phase, and so participants now, we're going to look at the level of adherence for them to stick to the program. So the coach and myself kind of take a step back. We still do see the participant bi-monthly, but it's to see if the participant will engage in that exercise activity or any changes, right, in the regimen after not having someone to kind of push you or guide you along. So that's what's happening right now. So with that being said, so the different components of the individual's health makes them up as a whole. So we have psychological, mental, emotional, physical. So what I do ask participants is, I give that example of the domino effect, right? So if you're not taking care of one component of your health, often at times if you have a domino and one topples, what happens? They kind of all tend to fall over. So as the individual aging, the adult living with HIV, we know that it's important to take care of their health. Many of the participants come to their screenings and they say, I know I should take care of my health, I know I should take care of my physical well-being, but I'm stressed with so many other things, balancing things on my plate. So they do join the study as kind of a kick in the butt to get started. And what I do see, and now that some participants are in their final assessment, being launched into phase 2, is a lot of change, and some positive, right, some negative, but they do say that, hey, they're eager beavers to get involved into the program. So I do say, hey, a change in one health component can really impact that change for another at times. This being said, that I see some of the mental health improving, right, with, I guess, attending those physical fitness assessments, even for testing, and they're kind of being on their own, that they do say, I feel better that I'm starting somewhere. So therefore, taking part in a community-based exercise program, what I'm seeing is that as a member of their community, it does provide them an opportunity to build those social relationships and encourage them to partake in physical activity. So with this, it's done, their assessments are done one-on-one. However, with participants, especially phase 2, when they have those 2 unsupervised sessions, some participants do pair up and have a gym buddy, for instance, and go to the gym. So we do encourage building community relationships. However, their assessments are done one-on-one. Yeah. Yeah. No. Are there? Yeah. Go.
Are people asked to not change anything in phase 1?
So this is what I'm seeing with the baseline monitoring phase, because as Kelly mentioned, right, the 120 people, they act as their own control. So what I'm finding is they come in for their screening, and then they come in for the bi-monthly assessments, and they may ask, am I not supposed to exercise? And I can't say that you're not supposed to exercise. So I do see changes where someone may, right, join the gym, or partake in, I don't know, an exercise class, like a yoga class 3 times a week. And sometimes they kickstart themselves because they know that they're going to be launched into a program. So I do track and document those changes. However, I can't say, refrain from exercise and don't, right, take care of your health. Yeah. So we monitor all those changes, right? Yeah.
So for the people whose goal is weight gain, is the program and the instructions from the nutritionists and all those things would be.
Right, so there's educational sessions. Also, they'll work on their goal attainment scale I mentioned, so with that fitness instructor. So working that into their exercise plan, and also tips, right, around dieting and eating, things like that. Yeah.
So I'm Soo Chan Carusone, and I'm the research lead at Casey House. And as you saw, Casey House collaborates with Kelly a lot on her work. And having this community-based exercise program is really exciting. And but in my conversations with Kelly, I always come back to, that's great, but how about the people who aren't going to be able to go to the gym 3 times a week, who aren't able to commit to that, who maybe have mobility issues, who that's not going to meet their needs? And maybe can we take a look at what we can do for people whose lives are a little bit more complex? So what we decided to do was kind of take a step back and say, how do we get to the point and understand what is necessary to get people to the state where they would sign up for such a thing? So really understanding someone's readiness to exercise. And because Casey House serves a more complex client group, we specifically wanted to look at people living with multi-morbidity. So those people living with HIV and at least 2 or more comorbidities or chronic conditions. So we co-supervised a group of master's students in the physical therapy program at U of T, specifically to do this. And this is the paper that they so gloriously had published with their work. But the purpose of it was to explore readiness to engage in exercise and the factors that influence whether or not someone feels ready to make that change. So readiness being someone's predisposition to engage in a health behavior change, and in this case, that being exercise. So we took a qualitative approach to this. So the students did interviews with 14 individuals who were living with HIV and self-identified as living with 2 or more additional conditions. So this is some of the characteristics of that group that they interviewed. So 9 were men, 5 were women, median age was 50. And as you'll see, 100% of them self-identified as taking their ARVs. But you'll see a difference from what Melanie had with a median of 4 concurrent health conditions, that this group had 9, most commonly being addiction, followed by asthma, cancer, hepatitis, and mental health issues. So we also asked them where they would fall on the trans-theoretical model, so where they'd fall in their readiness to engage in exercise. So as you'll see, most people said that they're preparing to engage in exercise, but 3 of them did say that they were actively engaging in exercise. So perhaps not surprisingly, we saw a real spectrum of people's readiness to engage. So there was, an individual who said, I'm kind of at the point now where I have to go to the gym. I don't even think about it. It's just like routine. It's religious now. And then there was other participants who said, exercise would be last in terms of priorities, except for my dogs. I don't think about exercise, to be honest. And there was a lot of different reasons for why that was, and there was, of course, people who fell in the middle. So we took their interviews and transcripts and spent a lot of time reading over them to really try to understand themes of what influenced where people were in their readiness to exercise and what they thought would help them, what would be an enabling factor to get them out to be able to do more physical activity or engage in a kind of structured exercise routine. And what we found was the most important factor was really just the complexity and episodic nature of living with HIV and the other concurrent conditions that they were living with. However, that being said, for all of these factors, we found in some cases it was hindering their readiness, so it was the reason why I'm not even thinking about exercise, but for some, they spoke from their own experience that because of their diagnosis or because their HIV diagnosis or because of their mental health diagnosis, they really relied on their exercise routine as their living strategy. So, on the facilitating side, it said, I feel exercise is even more important now being diagnosed with HIV because I think it can be a real positive to longevity in one's overall health. So in terms of what we actually mean by this, it was really the day-to-day limitations and the fluctuations. And again, as Kelly kept coming back to, was really the uncertainty of whether or not they would be able to get out of bed, whether or not they'd be able to get to the gym, whether or not it was worth that investment because they didn't know how they were going to feel from one day to the other. So although that was kind of the strongest theme that came through as what was influencing people's readiness, there were sub-themes that we identified within that, which was social support. So the value and of having someone to exercise with or a safe group and space to be able to do that. And I do say this again, that some people said because of their mental health diagnosis, they might actually not like group environments, but probably more commonly, people said that would be helpful and enabling for them. And there were the theme of perceptions and beliefs, so someone's attitudes and their perceived risks of exercise, and the priority that they gave to exercise. And then there's experience with exercise. So perhaps surprisingly to us, we asked them if their healthcare providers had spoken to them about exercise, and the majority of people said, no, surprisingly, they hadn't engaged in those conversations. And some of the participants who had said how helpful that was in having that conversation with a physio. At one point in time, it might have been when they had been hospitalized, but those exercises that they had been, or activities that were presented to them, and that education they really kind of took forward with them. And lastly was accessibility, and that could be accessibility in terms of the gym environment. And an individual talked about how difficult it was to get in and out of the pool at the local gym. But accessibility can also mean in terms of finances and being able to afford a membership or be able to get to the local gym. So in summary, we saw a real spectrum of readiness, and most important in kind of determining where someone was the complexity of their day-to-day challenges and the uncertainty of that, of what those would look like. And this impacted their willingness to be able to think about engaging, but also their ability to maintain exercise at points in time where they were doing it actively. So what does this mean? What are the implications for that? So I think one important thing is to consider the implications of multi-morbidity. And as Kelly was responding to Ken's question around uncertainty and what do we do with that, and how do we make programs reflect that, and whether that's the bit more flexibility in terms of it's not a set length of time, but people are able to come back into it if they aren't able to complete it, and being welcoming should they not be able to show up to set meetings, or what does that look like in program design? And then in terms of healthcare providers, I think really emphasizing the importance of their role in educating and introducing exercises, and the ability for them to address misconceptions and understand people's perceptions of risks associated with exercise, and make recommendations for safe and effective physical activity. So in addition to the BMJ open paper, as a result of this, we also have a kind of one-page summary, which I believe is back there if you want, or you can find it online as well. So I think we've kind of jumped around from a lot of different projects, but it comes back to there's a need for more healthcare providers and resources to support people with disability, and with a real opportunity for improving the exercise and readiness for exercise for people living with HIV. So Casey House is opening its day health program in March of 2017, and this is a really great opportunity to address some of the issues of access to physical therapy and rehabilitation specialists. But because this is quite unique in having a program like this and the accessibility to such an interdisciplinary team, so we will be adding, in addition to what we currently have, which is social work and nursing and massage therapy and recreational therapy, we'll be adding physical therapy, occupational therapy, art therapy, mental health specialists, caseworkers. But what does this model look like, and how do we make the most of having physical therapy added to this? And how do we make sure that we're integrating the work that they're doing into the interdisciplinary team? So, for example, as Kelly showed us all the benefits of an exercise program, it includes mental health, but we also have people who are specializing in mental health, and how do we make sure that we're working together as well as possible on helping our clients meet their own identified goals. So Kelly and I are co-supervising another group of Masters of Physical Therapy students, and the purpose of their project is to identify factors to consider when implementing physical therapy in a day health program for adults living with HIV. And this is both from the perspective of adults living with HIV and healthcare professionals with expertise in HIV care. And because we don't have a lot of rehabilitation specialists working specifically with the HIV-positive population locally, we will be inviting and hoping that some colleagues of Kelly's from the UK and the US will participate and share their experience within a day health program or similar sort of program, as similar as possible programs in other settings. So we'll be doing focus groups with people living with HIV and one-on-one interviews with the healthcare providers.
I'll just wrap up by saying sort of some of the bigger picture pieces that are going on in relation to this work is Realize, that organization formerly known as QWIGR, or the Canadian Working Group on HIV and Rehabilitation, is a national charitable organization that is really aims to bridge those traditionally separate worlds of HIV, disability, and rehabilitation. They work in various research, education, and policy and practice realms. This is their new logo. Their strategic plan, mental health is actually one of the key strategic directions of their strategic plan, and it kind of intersects these other areas around aging, access to rehabilitation, and labor force and income support. And they developed something called the E-module, which is an online, openly accessible 250-page document now that is a resource that was developed specifically for rehabilitation professionals working in HIV care. That module is online that you can access. If you just Google, you'll be able to access it as well. But there's a group of people being led also by Patty Solomon who have been working on adapting this module specifically for community-based organizations and people living with HIV. So here are some of the take-home messages from today. That's been a lot of information from a lot of directions. And just again, want to acknowledge all the individuals who have been involved in these various projects along the way and continue to be as well. So thank you.